Hi, this is Rajesh Kakwani talking to you on posterior malleolar fractures. I'm a foot and ankle consultant in Northumbria Healthcare NHS Trust in Newcastle upon Tyne. Disclosures, none. I do have to acknowledge my colleagues in BOFAS, Trauma, and the Northumbria Foot and Ankle team for sharing some of their cases and slides. Now, why is posterior malleolar fractures important? Now, posterior malleolus is one of the static stabilizers of the ankle, which stops the posterior translation of the talus. It forms an intricate part of the syndesmosis. Now, what causes the stability of the syndesmosis? The syndesmotic ligaments are the anterior inferior tibiofibular ligament, which contributes to 35% of the stability of the syndesmosis. The interosseous ligament contributes 22%, whereas the posterior tibiofibular ligament contributes 42% of the syndesmotic stability. Now, if you have a completely undisplaced fracture of the posterior malleolus and you've stabilized the rest of the ankle, it should not be a problem. But the problem comes when you have additional ligamentous injuries. There have been cadaveric studies which have showed that if there is disruption of the anterior inferior tibiofibular ligament, and there is a posterior malleolar fracture which is more than 40%, and deltoid ligament injury, then these ankles are prone to have a posterior subluxation of the talus. And if these elements are involved, then it is important to stabilize these elements individually and together as well. Now, when we take routine lateral radiographs of the ankle, the plain lateral films are generally not very good in diagnosing the extent or the involvement of the posterior malleolus. In Newcastle, we do recommend CTs for all ankle fractures which have any history of dislocation. If you are suspicious that they may have a syndesmotic injury or there is evidence of posterior malleolar fracture. Now, there are a couple of classifications of posterior malleolar fractures. The most famous ones are the Haraguchi classification, where we've got type 1, which is the standard posterolateral fragment. Type 2 is when the posterior malleolus is split vertically into posteromedial and posterolateral fragments. And type 3 is just a tiny flake avulsion of the posterior inferior tibiofibular ligament. The Mason classification is very, very similar, although in reverse order, where type 1 is the PITFL avulsion type of fracture. Type 2A is the posterolateral fragment of posterior malleolus. Type 2B is similar to the Haraguchi type 2, where there is posteromedial and posterolateral fragments. These are important to identify, as we'll see later, because they are commonly associated with further articular damage. Type 3 is a large posterior malleolar fragment, which involves almost the medial malleolus as well. These are generally caused by axial loading injuries. Now, as we said, it is important to know the type or the classification of the posterior malleolar fracture, especially so for the Haraguchi type 2, which is frequently underdiagnosed and is quite a significant injury with articular damage, as well as the posteromedial fragment can be missed. So if we have a trimalleolar fracture, which is common in our day-to-day practices, and you encounter these fractures, and when they are fixed generally by junior medical staff, and you are asked to review these x-rays in your post-operative fracture clinics, you would notice that there is something not right in these x-rays. If you look closely, you'll find that there is a double shadow in the fibula, which prompts you that it may be malreduced in rotation. You also see that there is a double shadow in the tibial plafond region. And if you look closely, there's a significant articular step in the posterior malleolus, which is obviously shadowed by the plate. If you do a CT scan in these cases, you'll know the extent of the posterior malleolar displacement. And in these cases, where there is a significant displacement of the posterior malleolus and there is posterior subluxation of the talus, you get point loading of the weight through that area of the posterior part of the distal tibia articulating with the talus, causing excessive wear in that region and secondary osteoarthritis. Now, how much of what extent of the posterior malleolar fracture fragment is important? We generally try to measure the anteroposterior length of the distal tibial articular surface and quantify the posterior malleolus in percentages of that area. Now, there is evidence in literature where they say that the degree or the percentage of the posterior malleolar involvement does not have any significant evidence to support whether or not they should be fixed or not. Neither is there significant evidence whether more than 2 millimeter displacement should be fixed. Now, Odak and al. Did a systematic review of posterior malleolar fractures and found certain prognostic factors like the initial fracture displacement and dislocation are associated with poorer prognosis, as is residual joint incongruity, as well as talar subluxation in the postoperative films. Now, why do we bother to fix the posterior malleolus? There are anatomical rationale as well as clinical rationale behind it. The anatomical one being we need to restore the joint surface and the stability of the joint, and we need to restore the stability of the syndesmosis. Clinically, we need to reduce the fracture displacement and stabilize it in the reduced position. We need to restore the joint congruity, and we need to avoid the talar subluxation. Now, which technique do we use to fix the posterior malleolus? The easier one to do is anteroposterior screws. They are very easy to put in, but they do not they need an anatomical reduction prior to that stabilization. And it is very difficult to judge that anatomical reduction, especially in the image intensifier films. But it defies logic. You're trying to screw the entire body onto the foot. Although it is the basic AO technique, but it's not the current concept. Now, if we see the posterior malleolar fracture, the forces that are sustained by this posterior fracture fragment are the shear forces, which tend to push it upwards. Now, if we do fix them anteroposteriorly, there's evidence to show that these shear forces may cause further displacement, and the anteroposterior screw is not in the best biomechanical construct to avoid or to resist these shear forces. Now, there is cadaveric study by Bennett et al. In which they stabilized the posterior malleolus with anteroposterior screws and posterior buttress plates, and they found that the posterior buttress plates were much more stable in cyclical loading, and they caused the clinical correlation for this would be that posterior buttress platings offer accurate stable reduction, allowing early range of movement and earlier weight bearing, and hence improve the healing of the cartilage injury. Now, if we correlate it to a common Wohler-Barton's type of fracture of the distal radius, these fractures have a shear force which causes the Wohler-Barton's fracture fragment and the carpus to subluxate volarly. Now, if we compare it to the posterior malleolar fracture, we find that if we reverse the or turn it to 180 degrees, it is very, very similar to the Wohler-Barton's fracture, and it also has shear forces. Now, you would never fix a Wohler-Barton's fracture with a dorsal buttress plate with screws from posterior to anterior. What you would do in a Wohler-Barton's fracture is put a buttress plate on the volar aspect to avoid those or resist those shear forces. So why would you do something different for the posterior malleolus? You should also have a similar posterior buttress plate which would avoid or resist those shear forces sustained by that posterior malleolar fracture fragment. Now, it is much, much better to bolt the foot to the patient rather than the reverse way around. Now, in cases of those flake avulsions of the posterior malleolus, where on the lateral view, the posterior malleolar fracture fragment does not involve the articular surface, these should be treated more as syndesmotic injuries, and it is necessary to stabilize the syndesmosis. So if you've got a posterior malleolar fragment which is fixable, that would in fact stabilize your posterior inferior tibiofibular ligament. If not, they have to be treated as syndesmotic injuries with appropriate stabilization, generally in the form of syndesmotic screws. Beware of the type 2 Haraguchi, in which the posteromedial fragment is often missed, and hence it is important to do CT scans, and that posteromedial fragment may need a separate posteromedial approach and a buttress plate to stabilize it similarly. Now, if we come back to a common scenario of a trimalleolar fracture with a fracture dislocation, in our unit, we would primarily reduce it and stabilize it in a back slab as soon as possible after the injury in the accident and emergency. If we have to fix these fractures, we generally do a CT scan beforehand in order to see the articular comminution and the extent of the type of the posterior malleolar fracture. As you can see in the top left, these fractures type 2 Haraguchi are associated with a lot of articular comminution in the weight-bearing area. Unfortunately, these generally happen in younger individuals, and if this articular surface is not restored, it has a high chance of developing secondary osteoarthritis. You can also see the degree of articular comminution in the bottom right CT scan image. Now, we do commonly use a floppy lateral position for these cases, which allows us access to the posterolateral aspect of the ankle, as well as if the hip rotation permits, we can then external rotate the hip and give an anteroposterior view, which helps in fixation of the medial malleolus. This has been published by one of my colleagues, Mr. Murthy. Now, for these fractures, so the sequence of my approach for these fractures, if at all possible, I tend to fix the fibular fracture with restoration of the fibular length, alignment, and rotation, i.e. reducing it anatomically. The factors which helped me decide whether the fibula was restored back to length was the dime sign, as well as the congruency of the lateral malleolar talar articulation. Then you take lateral views to ensure that the posterior malleolar fracture has been restored back to length. You may need additional anteroposterior pointed reduction clamps to reduce and compress that posterior malleolar fracture. You would generally need to use a posterior buttress plate to stabilize that posterior malleolar fracture. In Haraguchi type 2, you may need additional anteromedial plates for stabilizing that, posteromedial plates to stabilize that posteromedial fragment of the posterior malleolus. You should also assess the syndesmosis, especially the AITFL, and if that is unstable, you may need additional stabilization of the syndesmosis using either tight ropes or syndesmotic screws or whatever suits you in a similar fashion. Now, if you get a posterolateral malleolar fracture fragment, it is very, very important not to elevate off that PITFL insertion on the posterior malleolus. So it is important to restore and maintain that PITFL attachment to the posterior lateral malleolar fragment. The buttress plate should be at the apex of the posterior malleolar fragment if possible, and the screw which stabilizes in an anti-glide fashion should be as close to the apex of the posterior malleolar fragment as much as possible. Now, depending on the degree of the comminution of the posterior malleolus, if it is the Mason classification type 2A, in which there is a posteromedial, a posterolateral fragment, you can use a posterolateral approach. Sometimes you may need a posteromedial approach for the displaced posteromedial fragment, and in certain cases, you may need both of these approaches if you have to put buttress plates on both of them, i.e. the posteromedial and the posterolateral fragments. The posteromedial approach is also quite easy to perform. You retract all the flexors medially and just go medial to the tendoachilles. In the posterolateral approach, you go between the peronei and the flexor tendons. You need to be aware and protect the sural nerve, which is exactly in the middle of the incision, which is generally between the tendoachilles and the posterior border of the lateral malleolus. Now, we await the results of the study, which is a prospective randomized controlled trial where open reduction internal fixation versus in the form of either plating or screws is being studied in Netherlands, and the results of these should be available in 2024. So the take-home messages today would be: have a very low threshold for having CT scans to help classify your posterior malleolar fractures. Posterior malleolar fractures are associated with a poorer outcome, and if the fragment is big enough, it is best to fix it with a posterior buttress plate. This restores not only the articular surface, but also stabilizes the posterior aspect of the syndesmosis. If it is a flake avulsion or a sleeve fracture of the PITFL, then it is best treated as a syndesmotic injury with stabilization of the syndesmosis. And if you need any further information or any clarifications, please contact me.